Okay. Well, I'm really looking forward to this conversation because this node, I think, had the potential to be quite transformative, but I want people's inputs and ideas and let me know what you think. But basically, the primary care services and quality node is responding to a common, I'll just call it complaint from autistic individuals or their family members that their primary care provider, whether it's an internist for adults or a pediatrician for children or psychiatrist, quite frankly, don't seem to understand the needs of autistic patients and often are not only ignorant, quite frankly, of the needs, but don't seem kind of motivated to learn more or anything like that. So the problem that we in the node identify is that autistic adults have a higher prevalence of co-occurring medical conditions with limited access to healthcare. And these same co-occurring conditions may have their origins in childhood as well, especially for anxiety, ADHD, obesity, some of the ones that we've been talking about. It's not that they all of a sudden show up at age 18 with those conditions, like they've been, developing over time. And there's a lack of physician training for working with autistic individuals. I have to say that is true, but I also, when I get in front of doctor groups, I say, okay, there's no training, but like, what kind of training are you looking for? There's like the condition itself, perhaps, and the identity and the disability kind of advocacy aspect. But when it comes to being a good doctor, like listening, engaging the patient and family members in a care plan, there are some basic skills really that if they did even just those better, the autistic patients could get better care. And quality of care is defined on two dimensions. There's technical quality of care and then interpersonal quality of care. And technical quality of care is like making sure you do a screening cholesterol at the right intervals, making sure they're all up to date on their immunizations, things that you can check off the list. Interpersonal quality of care is really how satisfied the patient is with their interactions with their physicians. So, you could have a physician who does one or the other well, but not necessarily both. And so somebody could be really good at making sure that the patient is all up to date on their, scheduled health maintenance things, getting their mammograms, getting their colon cancer screening, but then not so great on the interpersonal. And so even though that physician is technically high quality, if the patient experience is so awful they don't want to come back, that kind of doesn't matter. On the other hand, you could have someone who is also super warm and understanding, but then not doing the screening, not identifying the high blood pressure, and then that doesn't serve the patient well either. So the mission of this node is to improve primary care for autistic adults and children. I mean, at least get them equivalent and then raise the quality bar for both, and incorporate guideline-driven practices for the general population with personalized accommodation, sort of the example that I gave. The research agenda for this node is to promote autistic individual self-determination in healthcare. And so definitely, regardless of the intellectual level of any patient, getting input in some way and not just following a family member's agenda. Enhancing primary care provider training, which again is not that difficult when it comes to the actual knowledge, but I think there's a lot of sort of anxiety and a little bit of like being overwhelmed for physicians when an autistic patient is in their exam room and they feel like, well, I don't know anything about autism. What can I do? What can I do? And then just refer them off to somebody else, as opposed to giving them more confidence and saying, no, you got this. You can take care of, very medically complex patients, and it takes a little understanding and patience, but you'll get there. And then overall, for both populations, pediatric and adult, improving mental health and psychiatric care. A lot of it is an access to care issue. So in primary care for non-autistic patients, at least in the adult world, we take care of a lot of the mental health issues as frontline providers. And then refer to psychiatry when it gets more complicated. So we probably could handle, 60 to 70% of all mental health issues in primary care on the adult side. That is not the case in pediatrics. And so from a prevention perspective, even if you identify these behavioral issues that are likely to kind of slide into a mental health issue, in pediatrics, there's often, only 25% of issues, mental health challenges in the pediatric population ever get addressed. And only 25% of those are even adequately treated. So you can see where this mental health crisis, even pre-pandemic, just balloons in adulthood because pediatricians aren't really well equipped to deal with mental health issues. Okay. So if any of you attended the February 2021 webinar, I talked about this needle anxiety program. So one of the reasons I raised it is sort of this idea that I have that I mentioned in the health services breakout, which is I would love to see research on autistic patients kind of lead the way for better care for all patients. So the needle anxiety program to me is an example of that, where 10% of the population across the board has a fear of needles. And for very many of them, that fear is so great that it leads to just avoiding going to the doctor, avoiding going for any immunization because they just are so anxious about getting the needle, injection. And so a year or 2 years ago, we implemented a pilot where we were able to go through this like 2.5-year process to implement this idea of, in a primary care office, the ability to train our medical assistants to be more patient in the administration of a needle, training them to not say it's not going to hurt when it is going to hurt a little bit, a pinch. And then using very common modalities like cold or vibration distractors on the area that's going to get a vaccine, and then using numbing cream, which is very widely available for, more I guess not more intensive procedures, but often not bothered with for just a simple vaccine or blood draw, and training an RN to be able to administer that within a primary care practice. So in that webinar, I went over the details of that. And you can look for more, you can look at the recording if you wanted to hear about the whole program. And we are coming out with papers and also like a manualized protocol to share what we did at UCLA and just like distributing it to anyone who wants to try to implement this in their own institution. But if we were able to disseminate this and everybody did this, then what you would see is like, okay, well, yes, I do have patients who have like a maybe more intensive response to the fear of needles, and then makes it very difficult because their parents are bringing them in for vaccines. They don't really have the option of avoiding as a, an autistic, as a non-autistic individual might. So their parents are bringing them in because the parents want them to have these vaccines and blood draws. And so that population allows us to develop this intervention, which when we implement it can be available to anyone. So actually, even though this program was targeted towards one of my, like very, maybe more like higher needs patient population, maybe a flu shot is not the thing, but if they have seizure medications that require lab follow-up, or they have diabetes that require lab follow-ups, like, it's not okay that we don't do those lab follow-ups just because they're afraid of needles, right? So overcoming that in some way allows this protocol to exist and then disseminate it to everyone. Next, I have the slide. Next slide, please. Okay, and then this has led into the current project that I'm doing, which is very broad. This is a big one, which is just to completely redesign the way that primary care services are offered to autistic individuals. And this one is not dependent on the doctor per se. It's like a complete system redesign, a reorientation framework for what autistic patients need in the primary care setting. So again, I'm not letting the primary care doctors off the hook. They have to figure out how to do this or adjust their office to identify a group, like a team, to be able to provide this through the primary care office. So one is diagnostic clarity. This probably really boils down to if you ever have been through a developmental assessment, what kind of kills me is, and I deal with this all the time with my patients, is you send them to someone who does an assessment. They, do all the testing, you bring them back, they bring them back for the results. There's always like a, discussion for the results. And the diagnosis is made and a plan is formulated, and the patient usually receives, or the parent, like this 40-page document that has all the assessment results and 25 recommendations for their child. And then the explanation from an assessor is like, here you go, good luck. I mean, maybe I'm over dramatizing, but that's literally what so many parents describe for me over and over and over again. And I just think, like, in no other place in medicine would we put the burden of figuring out a treatment plan solely on the parent. Like, it would be the same as saying, well, I've been having chest pain. Okay, let's get an echocardiogram. Here are your results. You've got mitral valve prolapse. You got this and that. Here you go. Go find yourself a cardiologist, a cardiovascular surgeon, just figure it out on your own. I mean, it's just ridiculous. And so I have exhorted so many neurodevelopmental specialists to say, loop in the primary care doctor, because what I do is then sit down, I warned my parents that that's going to happen. And I said, don't worry about it. Don't get so anxious. Like, just bring me the report. We'll go through it together and we'll figure out the priority. You don't have to do all 25. Because that's a lot for anybody. That's a full-time job. That leads to parents quitting their jobs and putting their families into more financial stress because they got to figure this out on their own. So that's diagnostic clarity. Care coordination, I think, is more commonly known. Transition planning, healthcare transition is another set of services that should be happening in primary care. Parental support, I think, is something that primary care, especially pediatricians, do well. They just don't bother to do it for the autistic patients, and I have never figured out why. And then behavioral management and parent training is, something that probably relies some partnership with either a social worker or a psychologist. But I do think that this is preventive or supportive for kind of addressing issues before they escalate or snowball into something more serious. And then finally, educational advocacy. I mean, we all know very well that parents can struggle in the IEP meeting, especially the first time, or when they are they don't know themselves yet the kinds of services that schools can provide. So again, it kind of kills me when the pediatrician recognizes they're going to be going through the IEP process and there's no discussion, there's no support. I trained a social worker in our pediatric office to actually go to IEP meetings with families, not every single one, but especially when it's their first one. And then also if the parent expects that there's going to be some contention or a little, kind of negotiation needed for with the school or school district, because it can be very lonely to be a parent going to an IEP meeting by yourself and then seeing 10 other people from the school. And our social worker will go with them. And oftentimes that representative from the health system diffuses the tension, and the parent has a good advocate who can more reasonable, be portrayed as not someone who's just advocating for their kids, so they're going to ask for everything. I think my social worker, or sometimes I go, or sometimes our psychologist goes, depending on our availability, to just let the school know, no, what the parent is asking for is actually reasonable, and that often, makes it a little more successful to treat our patients. So I'll stop sharing at that point and just hear responses and see what people think. Anybody?
Yeah, I have a few questions, but since I have access to you, I want to let anyone who has a question ask. If not, I will get it started. I think the structure is beautiful. I am so looking forward to the implementation of this system in Len Clinic and other clinics what a beautiful revolution. And absolutely, I agree with you that looking at this population and what we find in this population can definitely help us on a mass scale, because we can all benefit from the improvements to this. So I had two questions. Wondering, I'm sure it's integrated in this format, but how do we best meet communication issues that might result from having autism for adults patients that, you know, are on their own, if there's a tool that works for them best? And then if there are particular trends that you notice with these patients that we can use to train other providers on those issues, like needs that they keep, you know, bringing up, or supports that they need to keep accessing, that we can, you know, create a training, and maybe that will help primary care providers feel more comfortable.
Right. No, those are both really great questions. So the first one that has to do with communication, again, I think that this is not for providers not to be intimidated, because I think there's just a general bias against disabled individuals, whether you're a doctor or not, and doctors are not immune to that kind of bias. So oftentimes when, and then, you know, if an individual is actually nonverbal, so to speak, like it's very unlikely that they'll come in by themselves. But so in the lines of communication challenges, I would say we have patients who have dysarthria, whether they're autistic or not, where the clarity or the articulation is not that clear. We also have patients who may have kind of disorganized thinking. So whether it's autistic or any other kind of mental illness, not like bipolar or schizophrenia or schizoaffective disorder, that all kind of in the same category. And then you layer on that like many seniors or older folks with any kind of brain issue, or, you know, some sort of like a dementia onset or post-stroke, like autism communication challenges are not actually limited to just autism. So it's a bigger population than just autism. But with any communication disorder, I think as a clinician, patience is number one, and kind of the burden is on us as a physician anyway to ensure that our patients understand what we're saying. So if in the patient encounter you suspect that there may be an understanding difficulty or a challenge, like, you know, we simplify our language so we can get down to sort of living room language, and making sure, like, ask only one question at a time, and then to make sure to check for understanding. And if it's anything like kind of big, like starting a new medication or, you know, proposing some sort of procedure, then probably checking in with some individual who knows the patient well enough, who can kind of reinforce the messages at home, I think it's a big thing. And your second question had to do with, I had an answer, but what was the question again?
Sure, yes. Just tendencies that these patients tend to have either in needs or access that we can train primary care providers
to that's a good question. Yeah, absolutely. So part of the research of this node is to identify these issues. So for example, in AIR-P, we have from the research agenda, you know, community-based lifestyles, healthcare transition, sexual, reproductive and gender health, and then neurology and genetics. And those from our initial preview of the literature and interviews was what informed the nodes and our agenda. But I will say, for example, something that keeps coming up is GI issues. And again, clinically, what I see is that you know, there's not a ton of what I would consider sort of like, you know, gold standard research showing a connection between GI and autism to be unique. In other words, my perspective in asking the experts is there's an overlay of GI problems in kids who are autistic, but there, like, a lot of non-autistic kids have GI issues also. So part of creating this team, I'm looking into, I'm narrowing down like a partnership with a GI specialist who can help us break that apart, tease it apart, figure out what's really going on, and then start publishing on that, because I think that is also something that pediatricians and adult primary care providers need to be able to address. there's a lot still to be done, I would say, for that question. It's not like we know everything yet, but part of these kind of conversations is to think about what's missing, what you all are seeing in your own practices or in your own institutions, and then sort of letting us know, and we'll, if there's enough interest, we'll make it another note or get it in there to be looking at further. Oh, it will end in 1 minute. All right. I apologize. I hope that was interesting. Please feel free to email us or contact us if you have ideas.